through it, and I can use another modality like heat, but that has stopped. I carry on with the ESD again. There, the whole lesion is resected now. Another case from our similar registry. This is a patient with colitis and a DAM. You can see the scarring. See, the lift is very, very poor. The whole lesion is very scarred. In a colitic bowel, which is very vascular, it oozes. You cut, you ooze. It's just constant oozing in this scenario. It's very, very annoying. So you have to balance the use of coagulation current with this. So look at that. The scarring was so bad. The lesion is split, but it is off. And now right into the base, there's an oozing vessel. You see that? I can use coag grasper, but again, I'm very worried because of the risk of perforation. So we use Purastat there on this bleeding point, and you just observe. Again, it's transparent, so you can see the vessel has stopped oozing. There's no more bleed now. I'm very happy and confident it stopped bleeding. Oh, sorry, so that's why. So far, this is 30 patients. We've got 10 more patients now. But as I said to you earlier, that this is the distribution of our patient population. Bulk of it is in Barrett's, rest in stomach and colon. And that's what we found in about 76% of the patient. Purastat alone was effective in providing hemostasis. So from this, so far, all I can conclude is it's a very effective hemostatic agent. It controls the venous oozing very well. It does not interfere with the continuation of my resection procedure, like those white powders or clips or anything. It's safe. There was no technical issue at all. Very easy and safe to deliver. But I think it still needs a little bit more evaluation to be sure that this is a very effective product. So we now started a randomized control trial where we're going to compare Purastat with heat therapy during ESD. So we're recruiting patients who are having colonic ESD and those patients who are having esophageal ESD, and we'll randomize them into Purastat versus heat alone, which could be knife, which could be coag grasper, could be anything. And our primary aim is to see if we can reduce the intraprocedural use of heat therapy, because I think that's where perforations happen. And if we can reduce the use of heat for bleed control during ESD, I think ESD will become a lot more safer. So we just started recruitment into this study. If any of people here are interested, then I'll be very happy to talk to you about it. Just to finish off, don't go away thinking this is a solution to all types of bleed. I think this is an extra tool. It's a complementary tool. This is an SM invasive cancer in Barrett's. We're resecting this, and you'll find that you'll get simple bleeds and oozing. Especially when you have invasive cancers, they're very vascular. You'll see a lot of ooze. So that's a ooze which is happening. That's an ideal kind of bleeding for the use of Purastat. Purastat will work here. This is the type of bleed where you use Purastat and you will not be disappointed. So there we use the Purastat, give 30 seconds or so, the bleeding will stop. You can continue with the further resection, and you'll see as we carry on with the resection, you'll come across big vessels. Now those big vessels have to be treated with respect. And we have very effective tools for those, and use those effective tools there. Now big vessels like this, when they open up, they're not for Purastat. That's where you prophylactically use your coag grasper and coagulate them. So please do not put that away. Coag grasper is a very effective tool. Use it effectively. What I want to show in my last video is the type of bleeds where you should not use Purastat. This is another Barrett's case, very scarred lesion because there's a recurrence after EMR. So that's why we're doing ESD. And as I said to you before, whenever there's recurrences, whenever there is Barrett's lesions, there's very vascular, there's a lot of oozing and bleeding. So everything is going well. And suddenly we get a very aggressive bleed. So this is an arterial spurt. It's complete waste of time using Purastat here. Don't use it. So I feel Purastat is a product which is complementary to other hemostatic agents that we have. So this is where we have to use coag grasper. It's very dangerous, so you need the skills to use it safely, but that's where Purastat should not be used. So I'll finish off with my conclusion saying it's very safe because it's a very synthetic, inert, and a non-infective product. It's very quick and easy to deliver because it does not require training. clips require training, use of hemospray requires training. They all require some sort of skill, but this is a product which can be really put down into the right side with very little skill set. We haven't encountered any blockage of catheter, but Professor Ponchon's got a lot more experience. We can ask him if he has encountered any problems. It's transparent, so it's visible. Hemostasis in front of you. You can see through, identify the bleeder, and treat more if you want to. And the most important thing for me is that this doesn't stop your show. The show continues. Whereas with all other products, the show stops after the hemostasis. So that's what I like about it. And I'll stop there and take any questions if we have. Thank you.
Thank you, Pradeep. Any question in the room?
That's a very good question. The question is about the application. So if you are applying it for immediate hemostasis, then you have to identify the bleeding point, make sure that the bleed from the bleeding point, the blood has moved away, and you apply it directly onto the bleeding point. So you have to be precise and accurate and drop it straight onto the bleeding point with minimum blood on site, then it's very effective. So that's for intra-procedural bleed. It is thick and it sticks well, so you can still apply it to areas which are anti-gravity. But you have to be very accurate, and you get it on the surface, then it can stick to the surface despite gravity.
Yes. I have a couple of questions along this line for hemostasis. Is this like an endoscopic glue that sprays on top of the bleeding surface and puts a coating on it so that it does not bleed? And do you follow this up with any other hemostatic device like clipping or whatever? And have you tried this with variceal bleeding? And does that stop with that?
That's very interesting. It does look like the glue, but it isn't a glue, and has got lots of advantage over glue, because glue is a nightmare to use. You can destroy your endoscope while using glue. If you don't use it properly, the glue and the tissue stuck. And I know of examples where endoscope is stuck to the stomach and they couldn't take it off because the glue and the stomach stuck together. So it isn't a glue, but looks like glue, but it works like providing a physical barrier and scaffolding which blocks the hole in the vessel, and then the natural process of clotting takes over. So that's how it works. Can you use other hemostatic modalities on top? Yes, that's the beauty of it, is that it doesn't stop you from using anything else. So you use it. If it doesn't work, you haven't lost anything, because you got very good visibility. You can use whatever modality you want. A clip, core grasper, other hemostatic agent, whatever you want to use.
Okay.
Variceal bleed, I personally haven't used it. I wouldn't recommend based on my experience, but Professor Ponchon's got a lot more experience. What do you think about variceal bleed?
No experience. I cannot tell you.
No. I would be a bit reluctant.
I think because of the situation where you're here, it's an ooze, you have a little more time, so you can take your time in order to take care of the bleeding. But my question was, what was the delivery system when you put the Purastat in? It didn't look like it was a needle. Was it a very large bore catheter? What was the delivery system?
Oh, that's very
to get
good.
it down there?
Delivery system is extremely simple. It's a very simple plastic catheter. So it comes with a plastic catheter and a syringe. You attach the syringe to the plastic catheter, put it down the endoscope, and drop it at the right point. There's no needle. So you just, a simple catheter, plastic catheter, which drops it there through a syringe. So not complicated at all.
Yes.
Please.
How long have you to wait before you continue with the operation, so to speak? Can you rinse directly, or do you have to wait 20, 30 seconds?
So I'll tell you first, that you can have others experience. I wait about between 40 to 50 seconds or 30 to 50 seconds before the hemostatic effect is seen. So that's what the time you need to allow for hemostasis to happen. Once the hemostasis happens, you do not need to wash it. You do not need to get rid of it. It's transparent. So you can work through it. So don't try to wash it off, and I'll recommend not to wash it off. But what do you think?
Same as you. Okay. Same as you.
Perfect. Toshi, you?
Yes.
Yep.
Same.
Excellent.
So